But that is our point, Prof. Chandra, because we I mean, there are still very seldom epidemiologists come up in this issue. So it's really different when we discuss it in Germany, for example. So many epidemiologists come becoming the like an actress, like an actor, yeah. But in Indonesia, we never heard the role of the epidemiologist. Although we have so many, I think
Right.
you also met with some one of them when you visited us in 2016. Yeah,
Yes, I remember.
yeah, he is a epidemiologist professor from UGM. But I don't
Right.
know. That's also my concern because I I feel that we lack of the role of the scientific perspective in the discourse in
Right.
media, for example. Yeah, that's really a pity, actually. Yeah.
Yeah, and today, we don't usually think about epidemiologists very much. They do their research in the background, but today I think their knowledge is very important. So I'll talk a little bit about some epidemiologic concepts and tie them to what is going on today as well.
Yeah, yeah. Okay. Yep. I think Baita, you can start. Yeah.
Okay.
Mm-hmm.
Okay. Shall we start, Santi? Are you ready?
Okay, the recording is already on.
All right. Okay. Hello, everyone. We will start now. Good evening for those with Western Indonesian time, and good morning for everyone with Eastern Daylight Time in the US. Welcome to our webinar series of Southeast Asia Talk, organized by the Center of Southeast Asian Social Studies, Universitas Gadjah Mada, Indonesia. I'm Ita Yulianto, your moderator today, and first of all, I'm pleased to tell you that our research center is a center of excellence in social science under the Indonesian Ministry of Research Technology and Higher Education. Second of all, this Southeast Asia Talk is our platform for international discussion on social science and the dynamic of Southeast Asia. And today we will continue to extend our discussion despite the fact that all of us is exhausted and restless being exposed by these uncertainties. We have Professor Siddharth Chandra from the American Institute of Indonesian Studies. Hello, Prof. Siddharth. Good morning.
Good morning, good evening.
Okay, and also Dr. Lukman from the Faculty of Medicine, Universitas Gadjah Mada.
Good evening, everyone.
Selamat sore, Mas Lukman.
Selamat sore.
Okay. Just time management, we will divide our discussion today into two sessions. The first one will be the presentations for both speakers in a row, and then the second one will be the question and answer session. And we also invite you to raise your questions in the chatting room, and then we will invite you later to decide which question that we will pick up. All right. Without overdue, I will invite Professor Siddharth Chandra, the President of American Institute of Indonesian Studies and Professor in James Madison College, Michigan State University, USA, and also Professor by courtesy in the Department of Epidemiology and Biostatistics at Michigan State University. Prof. Siddharth Chandra, the time is yours.
Thank you very much, Professor Ita Yulianto. And I would like to also convey my gratitude to the director of the Center for Southeast Asian Studies at Universitas Gadjah Mada, Bu Hermin Indawa Uni. Also to the staff who helped to set this up, and to our liaisons from the American Institute for Indonesian Studies. I think they are on, Johan Purnama and Faisal Adi. So let me start the slide presentation. And the topic of my talk, as advertised on your beautifully designed flyer, is lessons from the 1918 influenza pandemic for the current COVID-19 pandemic, a historical perspective from Indonesia and other countries. I usually give this talk when I'm talking to my students or to colleagues at universities. I talk about multiple different countries, but today, for the purpose of brevity, I'm going to focus primarily on what the work that I've done on Indonesia, and then to build a bridge across to the United States, because I live in the state of Michigan in the US. I'm going to talk a little bit about what we can learn from the example of Michigan as well for the management of pandemics. So very briefly, the influenza pandemic of 1918 has been called by two very prominent epidemiologists the mother of all pandemics. And the reason they called it this is many future influenza pandemics were caused by viruses that were shown to have descended from the virus that caused the 1918 pandemic. But we can also think of this pandemic as being the mother of all pandemics because of its sheer size. It was a global pandemic. It occurred in 1, 2, 3, or 4 waves, depending on which part of the world you were in. And the approximate death toll was a staggering 50 million people. So this was a really devastating pandemic, probably one of the 3 worst pandemics ever to have visited humanity. The population loss in Java alone was approximately 4 million. Now, when I say population loss, I'm not just talking about deaths. Usually in a time of pandemics, we also have fewer births, fewer babies are born. So if you look at the demographic impact of the pandemic in Java, it was about 4 million people. And in India, which was at that time a British colony, just as Indonesia was a Dutch colony, the loss in population was over 15 million. So this was an enormous event. In the United States, the death toll is estimated to have been about 675,000. And if you look at data around the world, there is evidence of the pandemic. If you look at statistical data on births, on deaths, on disease, on the economy, we see evidence of the pandemic. Now, just as the pandemic is called the mother of all pandemics, it was also until quite recently known as the forgotten pandemic. And the reason is, even though 100 years is a very short time, it's the blink of an eye for historians, it didn't take us very long to forget what had happened in 1980. And as a consequence, even today, there are numerous open questions about this pandemic. We don't know as much as we would like to about the demographic impacts of the pandemic, about its impacts on fertility and babies who are being born, about the effects on marriage, because a lot of young people were dying or falling sick as a result of the pandemic. We don't know as much as we would like to about the epidemiologic features. So, for example, when did the pandemic arrive in different places? How did it spread? When did it spread? How bad was it in different districts of, let's say, Indonesia? Did it evolve over time? As the wave moved from one place to another, did it become worse? Did it become flatter? And what were some of the factors enhancing or reducing the ability of this pandemic to propagate, to move across space? And then finally, and this is a point I'm going to spend a little time on, what is the effect of different types of interventions on the epidemic? So let's move on to the next slide. So one of the things I noticed when I started doing this research well over 10 years ago is I noticed that there were very many country studies. So most people who do research on this pandemic look at an individual country, they look at some districts or some states, provinces. There wasn't very much work on studies of the pandemic as a global event using statistical data. The end goal of the project that I'm doing, and you'll see just a piece of it, is to study the pandemic as a global event. Okay? But I'm still doing it through the lens of individual countries right now. And then, of course, what are the lessons for preparedness, for pandemic preparedness? Before I go into some of the actual research using data from Indonesia and other parts of the world, I want to talk about 2 concepts in epidemiology that are very important to understand when you're thinking about a pandemic. The first concept is something called the basic reproduction number. This is a term that many of you may already have heard. And what it is it's basically the average number of cases that a single case produces during its infectious phase in a susceptible population. The simple way to understand it is, if I am infected, how many people am I going to infect before I get better, right? And if I infect on average more than one person, let's say two, and then those two go in and infect two, and then those four go and infect two, you can see how you'll very quickly go from 1 to 2 to 4 to 8 to 16 to 32 cases, and the epidemic will mushroom out of control. Okay? So if the basic reproduction number is greater than 1, if I infect more than one person, let's say 2 or 3, then the epidemic will take off. Okay? And similarly, if the basic reproduction number is less than 1, let me go back. I'm just setting up my pointer. If the basic reproduction number is less than 1, let me try this one more time. Let's put a pointer, highlighter, and I'm just going to add a pointer here so I can show you some of the concepts that are important for this presentation. So if the reproduction number is greater than 1, the epidemic will take off. If the reproduction number is less than 1, it means that every person on average infects fewer than one person. So if you have 10 people, maybe they only infect 5 people. And those 5 people will infect 2 or 3 people, and the epidemic will die off, will dissipate. Okay? The 1918 influenza pandemic, the reproduction number is estimated to have been between 1.5 and 5.4. What does this mean? This means that that number was greater than 1, and the epidemic took off. Okay? We are finding that for the virus that causes COVID-19, the reproduction number is also greater than 1. And so it has the potential to take off if we don't create control measures. Okay? Just by comparison, for some other diseases, measles, which some of you may have heard of, is probably familiar with as a childhood disease, the reproduction number is 12 to 18. So it is an incredibly infectious, very, very infectious disease. Okay. There's one more epidemiology concept I want to share with you before I go into the work on Indonesia and Michigan. And that is something called a compartmental model. In epidemiology, when we are studying infectious disease epidemics like COVID-19 or the 1918 influenza, we normally use compartmental models to think about how the disease will progress. And what the compartmental model does is it takes everybody in the population and puts them into different compartments, into different boxes. Okay? So when a novel virus comes along first, you have a large population, nobody is infected, but everybody is susceptible because the virus is a novel virus. It's a new virus. Nobody has natural immunity to it. Okay? Then once the virus is introduced, some people become infectious. They get exposed and they become infectious. Okay? And those infectious people may infect other people, and then at some point in time, they will recover. Okay? And very often, usually when they recover, certainly with the influenza of 1918, they develop some kind of immunity to the disease. So we can basically remove them from our understanding of the number of cases that are going to occur in the future. Right? So this is the most basic compartmental model in epidemiology. There are more complicated models. There's another one called the SEIR model. That is where you have susceptible people who get exposed first, and then some of them become infectious. So the E stands for exposed. Okay? The S is susceptible, E is exposed, I is infectious, R is recovered. In the simple SIR model, S is susceptible, I is infectious, R is recovered. Okay? And then there are many other models you can develop. One is an SEIR model with quarantine, where you take some of these people out and you put them into quarantine. And that changes the dynamics. It changes the number of people who are going to get infected tomorrow and the day after tomorrow and so on. Okay? But these are two models I'd like you to keep in the back of your mind, two concepts. One is the reproduction number, and one is compartmental models as I talk about the 19. Okay. So the first question, probably the most basic question, is how many people died from the influenza? And one of the problems I noticed when I started this research is the reported number of deaths are almost always severe underestimates. Okay? It is very difficult for the government, even in the most wealthy countries, to keep exact track of what is happening with the number of cases and the number of deaths. All right? And so I noticed that the censuses tend to be much more accurate, but unfortunately, they're only done once every 10 years. And so the method that I use to look at what happened in Indonesia and in other countries is I said, let's look at the censuses before and after the pandemic, and let's calculate based on the censuses and the way the population is growing, how many people are missing during that time period, the time of the pandemic. Okay? So the basic idea is to estimate the population growth trajectory before and after the pandemic, to calculate the difference between the two trajectories, and that difference is your population loss. Okay? Let me give you an example. Here is a graph. For now, let's just focus on the red line. Okay? Let's say that we took a census in 1890, another one in 1900, another one in 1910. Okay? Using those three observations, we can calculate how the population was growing before the pandemic. And we can estimate, right, just before the pandemic, how many people we would have observed if we had counted the population. We can do exactly the same thing after the pandemic. We can look at 1920, we can look at a census in 1930, we can look at a census in 1940, we can estimate the trajectory, and we can calculate just after the pandemic how many people we should have observed. Okay? And this gap is the drop in population that is attributable to the pandemic. Okay? Now keep in mind, this is a population loss, it's not the number of deaths. Okay? Population loss is not the same thing as number of deaths because it also includes a reduction in the number of babies that are being born. We almost always see in times of crisis a significant drop in the number of babies who are being born. Okay? So we think about this not as the death toll, but as the demographic toll of the event. Let's move on. So for Indonesia, for Java, when I did that calculation, my estimate was approximately 4 million. It was much larger than the one estimate of the number of deaths that I've seen in the literature by Professor Brown. He wrote 1.5 million. We have some anecdotal reports from the Dutch East Indies saying that it was in excess of 2 million, the number of deaths. Okay, so let me talk a little bit about patterns of spread now. What are the patterns of propagation of the 1918 pandemic? Does it enter a location from particular seaports or roadways? Does it spread at a uniform speed? Does it follow transportation routes? Are some areas spared and are other areas infected? And what are some of the factors associated with this pattern? I have a lot of material on this subject, but I've left it out of the talk. I'm going to focus on what happened in Java, right? So what we did in Java is we actually calculated using monthly statistics on deaths. We calculated for each of the different kabupaten. So these are basically regencies in Java. Okay, each of these is a kabupaten. They probably look a lot like modern day kabupaten, but they're slightly different. Many of them are a little bit bigger. There has been what you might call perubahan, right, between 1918 and the present. So now today there are many more kabupaten. But these are the kabupaten of Java. And what I want to show you here is if you see a kabupaten that has a color in it, what does it mean? If the color is dark brown, it means that during that week, the kabupaten is experiencing its peak deaths. All right. If it's dark red, it's the second worst week. If it's orange, it's the third worst week. And if it's yellow, it's the fourth worst week. Okay? So if you see a kabupaten with a color in it, it is going through some of the worst weeks of the pandemic. And the darker the color is, the worse is that week. And what you will notice is by late October, we see the first few kabupaten peaking. We see Batavia, now Jakarta. It's got a little bit of a red spot. And then we see a group of kabupaten around Semarang, which are peaking. What does this tell us? Well, these are both northern towns. They're on the Pasisir, on the northern coast of Java. There was a lot of shipping that was happening between Indonesia and Europe at the time. There was a very vibrant economy. The Netherlands was not actively involved in the First World War, which had been going on at the time, but there were some troops coming and going also to the regular army in the Netherlands Indies. And so what you're seeing here is most likely the effect of ships coming from Europe, where the pandemic really took off during the First World War, and bringing the infection with them. This is the same pattern that we see in British India. It's the same pattern that we see in what is today Sri Lanka, what was then Ceylon, and a number of other areas in Asia. The pandemic came by sea, most likely on ships from Europe. Okay? So this is October 20. By November 10, most of the northern part of West Java and northern part of East Java is heavily infected. And then from these areas, which are the most exposed to the rest of the world, it starts spreading. If you know the geography of Java, you're looking at slightly more remote regions here. They're not as exposed to international interaction as these early places. Okay. And then finally over here, you see Cilacap. I think this is Pacitan, I think. This is probably, which one is it? It's in Daira Istimewa, Yogyakarta. I forget which one this is. But anyway, so these should all be familiar locations. They are relatively remote. All right. Now let me talk about, so we've seen at the macro level, what is happening in Java. Let me talk a little bit about what happens in one kabupaten within Java to give you, we're going to zoom in now and see what's happening in a kabupaten. This is a report from a Mr. Van Steenis. He was in charge of the health in Magelang kabupaten. And this is what he has to say. I mean, he said a lot more in his report, but this is what he has to say about what's happening. He says, moreover, with a few exceptions, it appears that the outbreak starts close to the large markets, pasars, as you know, and develops around them. This is very important. Everyone knows the markets which thousands of natives visit twice a week, swarming closely together. This should sound very familiar to you. There could be no better opportunity to allow the infection to spread quickly and effectively. All right? So, what does this mean in the context of how the pandemic actually spreads within Magelang? One of the nice things about his report is he actually talks about different locations in different weeks. So I actually made a little geographic information system using that information, and I'm now going to show you on a map what is happening. Now, most of the listeners are probably from the Gadjah area. You're probably familiar with the geography of Magelang. It's right next door to Sleman, right? The border of Sleman is down here, and then you go further down and you get to Gadjah, to the city. Okay? So what happens, I'm now going to show you week by week what is happening in Magelang. And this will give you a very good idea about how the pandemic is spreading within Java. So in the first week, October 11 to 17, the market in Muntilan and Magelang, those areas, they begin to see some cases. Okay, you're all probably familiar with Muntilan and Magelang, right? The next week, there are 3 other villages. These also have pasars, okay, that show some infections. The week after that, the bigger circles mean that we've gone from just seeing some cases. He upgrades this in his report to the status of a center. This has now become a center from which the infection is spreading. So Magelang and Muntilan are now centers of spread. Angluar has also become a center of spread. And we see 4 new locations. These are on the road to Purworejo now. Okay? So again, it's moving along the roads. It's moving along where people are coming and bringing the infection with them. And then finally, it starts moving out into the villages away from the main road, further up the hills. This is a topographical map. So here you have a volcano, for example, near Temanggung. And then finally, it moves to another center, Sawangen, on the eastern side. And then it reaches to slightly more remote villages, Ngablak and Pakis. Okay? So this is how the pandemic spreads in Magelang. I'm going to show this to you one more time, just so you can see it quickly. Okay? This is the beginning. And now you're going to see the spread. Right? Okay. So that's some material on Indonesia. Since we have limited time, let me move through quickly and tell you a little bit about what happened in Michigan. And I think this is relevant to many, many places in the world today where we are thinking about waves of the pandemic. It turns out that in Michigan, there were actually 4 waves of the influenza pandemic. Okay? The first wave, that a lot of people call the Herald wave, occurred in April 1918. And you can see the death rate. So this graph shows you the excess deaths in Michigan. Okay, so this is how many more deaths than you would expect at that time of the year do we see. And what we see in March and April 1918 is we see what's called a Herald wave. This happens in the spring. It goes away. Everybody says, okay, that was bad, but at least it's over. Okay? They have no idea what's coming. And what comes to them in the fall is a much more severe wave. This is in October 1918, right? And when this happens, one of the first places to get badly affected is the city of Detroit in Michigan. This is a very large city, major manufacturer of automobiles and so on. And the governor of Michigan, his name is Albert Sleeper, he says, look, this is getting bad. We're going to impose a social distancing measure. He basically put into place a ban. If you look at the lower left graph, he put into place a ban on gathering in places of amusement and parks and so on. Okay? And as a result, the wave dropped. But unfortunately, because of pressure from businesses and from economic agents in the economy, after 3 weeks, they relaxed the social distancing ban. They removed it. And 3 weeks later, what happens? We get another, what we call a trailer wave. Okay? So there was another wave that happened as soon as the ban was relaxed, another wave of infection. And then it subsided, and this was a really devastating wave. It took thousands of lives. But everybody thought they were done with the pandemic. Unfortunately, a year and about 4 months later, we had yet another wave. Okay? So the pandemic in Michigan actually took 2 years to work its way through the population. And it consisted of 4 waves: a herald wave, a fall and October, autumn of 1918 wave, a trailer wave in the winter, and then yet another wave in the winter of 1920. Right? Now, let me talk a little bit about why this happened. Remember that model: susceptible, exposed, infected, recovered? One of the issues with imposing a ban, a social distancing measure, is you are protecting your population. One of the problems with that is that population is going to remain susceptible. And so when you relax the ban, all of a sudden, these susceptible people can become exposed with the virus and you can have another. Okay? So what this timeline suggests to us is even after this really bad pair of waves in October and December 1980, there were still enough susceptible people in the population that when the conditions were right again, we had another massive wave of infection. So this is a little bit sobering. It's something to keep in mind as we go through the COVID-19 pandemic. Now let me talk about what happens in different locations in Michigan. And I apologize, how am I doing for time? I'm sorry, Bu Ita, I can't hear you.
You still have another 12 minutes.
Oh, wonderful. Great. Good timing. So now let me go down to the graphs on the left and the right. I want to focus first on the graph on the left, right? Over here, there are 4 different colored lines. What are the lines? The first 2 lines, the highest ones, the maroon one and the red one. Oops. These 2 lines are for highly populated counties. Think of them as kacamatan on the eastern side of Michigan. Okay, this is Detroit, the maroon one, and the red one is Washtenaw County, where Ann Arbor, the location of the University of Michigan, our neighboring university, is located. Okay, and what you will see about these 2 waves is they go up and they go down, they go up and down, and nothing really happens in December. So they are only affected in October of 1918. And this probably has something to do with the timing of the ban in relation to when the wave was happening. The eastern parts of the state of Michigan got hit first. The ban was put into place relatively late. The wave came down. There were probably not a lot of susceptible people around in December, and so the wave did not take off again. If we come to the central part of Michigan, that is the light brown graph, it's kind of really nice. There are 2 very symmetric bumps here. There's one in October and there's one in December. That is the county in which I live, Ingham County. It's the location of Michigan State University and of Lansing, Michigan, which is the capital of the state of Michigan. Okay? And what probably happened here is when the ban was put into place, some people had been infected and exposed already, but others had not. And so when the ban was lifted, we got a second wave. We got 2 waves in Ingham County, in my county. And then if you go further west to the other side of the state, to a county called Kent County, where the second biggest city in Michigan is located, Grand Rapids, that was out on the west. It was late in the pandemic. They didn't have many cases in the October 1918 wave. So when the ban was imposed, the most that it did was it pushed the wave, it postponed the wave of infections out to December after the ban was lifted. Okay, so you see the differential effects of the imposition of a ban on movement on different locations, depending on what stage of the first wave of the epidemic they were in. Okay? And just by the way, that wave in 1920 that you see up here on the top graph, that is one single steep spike. The reason it's a steep spike is all four of these locations, okay, Detroit, Ann Arbor, Lansing, and Grand Rapids, we all had our infections at the same time, and it just took off in one shot, right? To show you on, I have maps, but I'll skip those. Okay, so this raises a very interesting question, and it's a question that we are all grappling with today, right? And epidemiologists are thinking about. When is it best to impose and lift a lockdown or a stay-at-home order or a social distancing measure, right? We can get some insights from the compartmental model that I showed you earlier, okay? So what I did was I said, okay, we see what happened in Michigan. In Michigan, we had a single 3-week ban, and it was imposed on different counties. It was imposed at the same time, same date, October 19. But different counties were at different stages of the pandemic when the ban was imposed. So what we're going to look at now is, given what we know about the 1918 pandemic, if you are the governor of Michigan and you have a choice, when during your wave should I impose the ban? What is the best time to impose the ban, right? So I'm going to use an SEIR model. I'm going to do some calculations. So here is a calculation showing the epidemic with no intervention. No ban has been imposed. Around day 31, the 31st day of the epidemic, it takes off. Remember, the reproduction number is more than 1, so it's going to take off, right? And then at some point, enough people are infected or have recovered that they are immune, and the epidemic wave goes down. So this is the epidemic with no intervention. The first thing I'm going to do is show you some very simple cases of the intervention. What if you impose the intervention very early in the epidemic, when there are hardly any cases? What happens? Well, if you impose the epidemic, the time of the imposition is the red line, and the time when we relax it is the green line. I'm taking a 21-day ban because it is exactly what happened in Michigan. It was a 3-week ban, October 19 to November 6. Okay. If you impose it at the beginning, when there are hardly any cases, the only effect that you have is to postpone the epidemic. Because when you relax it, the virus is still around, people are going to get infected, and you're going to see the same wave. So this wave looks exactly like this wave. It just happens later in time, right? The second insight is, what if I do it very late in the epidemic? Well, then the epidemic has already happened. So it's really not going to have any impact. The much more interesting cases are when you impose the bans sometime during this week. And it turns out when you impose it has a material impact on what happens in the epidemic. Okay? So now I want you to remember one more thing. If you have no intervention, the number of cases is going to be the same as the number of cases if you have a very early intervention, which is the same as the number of cases if you have a very late intervention. Okay? But if you impose the ban in the middle of the wave, it turns out that you have a very different set of impacts. So over here, what I calculated, just to give you an idea of what happens in these kinds of epidemics, is on the horizontal axis down here, this is the day on which I impose my ban. And remember, it's a 3-week ban. And what I did is I calculated the total number of cases for every possible day on which you can impose the ban. Okay? And if you impose the ban too early, you're going to get the same number of cases because it has basically no impact on the epidemic. If you impose the ban too late, same number of cases. But if you impose the ban sometime in the middle, you actually reduce the total number of cases that are going to happen. And I'm going to show you this on a graph, right? So let's take a look. What if I impose the ban on the 53rd day, close to the peak of the pandemic, and suddenly, of course, my infection rate starts to drop, right? Then what happens is, when I relax the ban, I get a small jump in cases. Because remember, by imposing the ban, I'm preserving some susceptible people who will get infected later on once I relax the ban. So this is what happens if you implement the ban on the 53rd day. Why did I choose the 53rd day? The 53rd day is the day on which you minimize the total number of cases. Oops, this is the wrong graph. This should be 53. But you get the idea. I did this. This is the calculation for the SIR model. But you get the idea. Okay? You can minimize cases if you impose the ban at a particular time. This may not be the only thing you consider when you're doing this ban. A second thing that you may be worried about is, look, the peak number of cases is very high. We have 4,500 cases. What if I only have 3,000 hospital beds, right? Then I don't want the cases to go above 3,000. Otherwise, where will these patients go? How can I care for them? The mortality rate will be much higher, right? So a second criterion that epidemiologists like to think about is, how can I minimize the peak number of cases? And if you want to do that, it turns out you don't impose the ban on the 53rd day. You impose the ban on the 45th day. Okay? And it gives you a very different profile of the epidemic. Now, you've kept the peak number of cases below 3,000, which is very good. But what you've done is you've preserved more susceptible people. You've pushed them out into the second wave when you relax the ban. More people are going to get infected. Okay? And a third concept is if we want to equalize the number of cases. So the total number of cases in the first wave are basically you take these cases, you add them all up, right? This is basically the same as the area under this curve. If you want to equalize the area under this curve with this, then there's a third day. It is yet another day. It's day number 48 when you impose the ban. Okay? So what I'm trying to give you here is an appreciation for some of the kinds of things that epidemiologists think about when we are going through a crisis like this. When do we impose the ban? When do we relax it? What does it mean for the peak number of cases? What does it mean for the total number of cases? How many people are going to get sick today? How many people are going to get sick a month from? Right? Okay. So that's the epidemiology side. And then I'm going to end with just a couple of quick concepts. Did the pandemic evolve as it spread? I'm going to show you just two pictures. These are pictures for India. By the way, I saw the same phenomenon in Java. Okay, I just don't have the graphs ready yet. I'm actually writing that paper right now. But for India, there are three major cities for which we see a graph. This is Bombay, which gets the pandemic first. The wave comes earliest, right? This is over time. This is Madras, and this is Calcutta. And what you can see is the city that gets the wave earliest has the steepest wave and the shortest wave. The city that gets it second, the wave is less steep and it's a longer wave. And the city that gets it third, it's a relatively flat wave and it's a very long wave. Okay? And now remember, this may look like a flat wave, but even for Calcutta, the death rate, the excess death rate, it's gone up to 60, where it was only 20 prior to the pandemic. So even here, the death rate has tripled. Okay? So this is still a very bad epidemic for Calcutta. In order to make sure that this wasn't some kind of lucky thing that I saw in the graph, we actually did the calculations for all the districts of British India. And this district is a district that neighbors this district, Bombay. Okay? And this district is a district that neighbors this district, Calcutta. So we see a systematic pattern across all the districts of India, where the districts that are early have very steep and shorter waves, and the districts that are later have much flatter and longer waves. And this suggests that the pandemic is evolving as it moves across India. We found the same phenomenon for Java. Okay? And then finally, why was the pandemic so severe in Indonesia in 1918? Indonesia is a warm country. And we know that influenza viruses thrive in cool temperatures. So why was the pandemic so severe in a country like Indonesia? We can speculate. There are at least two reasons that come to mind. The first reason is nutrition. So when you read the reports of health officers in India and Indonesia, one of the things that they're repeatedly saying is populations which are not well nourished, if you go to districts where people are not well fed, the mortality rate from influenza is much higher. Okay? So that is one reason. And populations in general in colonial Asia did not have the levels of nutrition that populations in the colonial power countries like the Netherlands and Britain had at the time. And second, and this is speculation, but we have found some results that show this is the case in India. I haven't done it for Java yet. The more densely populated districts of India actually see larger losses of population in percentage terms than the less densely populated districts. I still have to test that phenomenon for Java, but we see this in India. What does this mean? Well, we know that the virus does not do well in hot temperatures. That means when somebody coughs and spreads the virus, if the virus is hanging around in the air for a long time, it's going to die. Okay? But if the population is dense enough, if people are very close to each other, then when somebody coughs, the virus does not have to spend that much time outside its host where it can survive and thrive. And the transmission is much quicker. And so if you have high population density, even though the climate may not be favorable for the virus, you may still have rapid spread of the virus and a very successful pandemic from the perspective of the virus, a very damaging pandemic from the perspective of people. Okay? So just some lessons. Influenza pandemics, and as you can see, this current pandemic can be devastating. Public awareness is very important. Understanding patterns of spread is important. Where do they come from? What can we do to prevent them? The timing of social distancing measures matters. Okay? If you do it all at the same time across all places, they're going to have very different outcomes when you lift these measures. And they can evolve, the pandemics can evolve as they progress. And you want to think about different strategies for different stages. If you have a very steep wave, you're going to have many patients, you're going to have a stressed hospital system. If you have a flat and prolonged wave, there are very different sets of measures you're going to have to take. And finally, nutrition and population density mattered in 1918. We don't know yet how much it matters in 2020, but we're going to find out as we do research. Thank you very much. One last thing, the World Health Organization has a very useful pandemic preparedness checklist. This was prepared long before the COVID-19 pandemic. If we had remembered the issues that we faced in 1918, we would probably have done much more to implement what the WHO suggested. And I think things would have been much better today. So in future, we should remember the lessons of pandemics and ensure that we are prepared for them. Thank you. And these are some publications that we've done over the past 8 or 9 years related to the 1918 influenza pandemic.
Can you hear me now, Santi?
Yes, thank you.
Okay, thank you very much, Prof. Siddharth Chandra, for sharing your epidemiological and historical assessments over 1918 influenza pandemic. Indeed, today, we hardly to understand why this COVID-19 has dramatically changed our life, the world, in all human dimensions. And you just told us from your presentation that this influenza pandemic in 1919 is also devastating that we should learn from. And you said that this influenza pandemic is the mother of the later global pandemic in the world. As well, you also mentioned about what does matter towards the pattern of the spread of the pandemic, as well as towards the eliminations of its spread by different models of protocols and alternatives in combating the epidemic, not only in Java, in Indonesia, but also across the globe. Thank you very much. Just a gentle reminder for all participants, you are encouraged to raise your questions. Feel free. You can put in the chatting room and we will ask you later in the question and answer session. Going forward, we will invite Dr. Lukman, who is sharing about his latest study in navigating cancer surgery care in limited resource countries during COVID-19 pandemic. Dr. Lukman, the time is yours.
Okay, thank you very much for the opportunity. So I will share the So first, I would like to thank to Bu Ita and Bu Hermi who invite me to join this discussion. So I'm a medical doctor working in field of oncology, particularly cancer surgery. So I would like to discuss about how to navigate cancer surgery in developing countries or low and middle income countries in response to coronavirus pandemic. So this is the outline that I would like to discuss. I would like to discuss about cancer care or cancer management in low and middle income countries, and before the pandemic, and then challenge after the pandemic come, and then what we have done and what we are doing now in response to the coronavirus pandemic, and what should we consider to implement the prioritization of cancer surgery with the ethical standard. So if we talk about the cancer control in low and middle income countries, we see that we have already many challenges or many problems in compared to high income country. So I would like to show a bit about the incidence of cancer. So this blue bar is the incidence, a number of cancer per 100,000 population. And the red one is mortality rate, number of cancer-related mortality per 100,000 population. So if we compare high-income country with the middle-income country or developing country, and this the rates in the world, we see that the incidence in high-income country is much larger than developing countries, let's say. But if we take a look the mortality, it looks almost the same. So it means that in developing countries, the mortality rate due to cancer is much higher. There are some factors associated with this because our patient came very late to the doctor. There are some patient factor and also some health system factor because of the inequality of the distribution for both the human resources who treat cancer and also for cancer center. We see here that the case fatality rate due to cancer is much higher in developing countries. So also the other problem is that the incidence or the proportion of the cancer patient will also increase during the time. This comparison from 2008, 20, and predicted in 2050, it will continuously increase. And by the time in 2050, there are many more cancer patients in developing countries compared to high-income countries. So what we have to do with the patient with cancer, because for cancer treatment and cancer prevention, it will takes a longer time than other disease. So we need more resources. Cancer treatment is very expensive. So for cancer diagnosis and treatment, we need diagnostic lab, we need human resources, pathologists, radiologists, and surgeons. And this already have a natural problem in developing countries because of the inequality in terms of number and also number of facilities, number of human resources or manpower, and also the distribution across the region. Because most of the cancer facilities are located in urban area, and we can see that people from rural area have limited opportunity to get diagnosed and treated. And also for the treatment, there are usually cancer treatment takes so long and involve many aspects of treatment like chemo, radiotherapy, and other thing that is naturally not cheap. It's very expensive. So and also this is for patient and this is for the healthy population or normal population. For cancer control, we need also prevention, improve the public education, public awareness, This effort also is very important in developing countries because we have lack of system and also lack of public awareness. We can see that many patients come to the doctor very late because they have lack of awareness. They are afraid to come to the doctor. They are afraid to be treated, and they prefer to come to the traditional medicine or alternative medicine because there is a misconception among the public about the cancer diagnosis and treatment. And also there is some universal problem in other health system, not only in cancer, because of the ownership of insurance and coverage of insurance. But luckily in Indonesia, we have already universal insurance starting from 2014, and it also covers some cancer treatment, essential cancer treatment. And also, developing country has a lack of a cancer registry, health system, and referral system. So we don't really have a solid program how to manage cancer and how to plan how many facilities we need in the next few years, and because we don't have the registry. And it comes coronavirus infection that spread very quickly from China and also to other region, or already become a global problem, including in low and middle income countries. And this really affect all aspects of health system, including in cancer. Although cancer is not the core, or we are not working directly to diagnose and to treat patient with coronavirus, but other field of health system will severely affected by this pandemic, including people who work for cancer treatment, for example, and also for mental health and for children care. They are all affected, and particularly for this impact to the cancer treatment. This virus spread quickly to the world. This is the starting from China in the end of December, and then first cases outside the China is in January 11, if I'm not mistaken, in Thailand, and then in Japan in 16th of January, and then Korea. But now it's spread quickly to all over the world, and this is number of cases per 100,000 population. We see that Indonesia is here around 9.9 per population, but this really depend on the how country diagnose the patient, how screen the population, and the community transmission, and how this coronavirus infection affect the health system. This, I think, Prof. Siddharth Chandra already talked about how country respond to this pandemic. So there are some systems developed by Global Health Security Index, and WHO also rate the how country preparedness and also response status to COVID-19 depend on the ability of the country to do prevention, detection, rapid response, health system, and compliance to global norm. This is many high-income countries. They are in the I think they score better than a developing country. It means that developed countries suffer more because they are not ready and not prepared enough to fight against this coronavirus. What happens if we have a coronavirus infection and corona pandemic in our region? It will affect all aspects of our life, not only from health system, but also from economy, business, social, education, migration, and also research that we also severely for treatment or how to control this pandemic. We need this is I took the photo from Jakarta Post last month. Our president checked the preparedness of in some hospital in Jakarta to tackle the pandemic. So when there is pandemic, the hospital and health system need to do screening, testing, diagnosing, and then treat the patient, treat the critically ill patient, and do tracking. And also we have to provide the health worker who work to treat patient with coronavirus with protection equipment, and also we have to prepare medicine, emergency, and intensive unit care. This really will contract the health system because the resources from the hospital and also the health facility, they will be concentrated to tackle this. And it will impact for the other field, including cancer, mental health, and children care, because to preserve the resources, both human resources and also the medicine and the PPE or protective equipment. So non-essential medical care should be postponed. So what happened with the cancer care or surgery, cancer surgery in developing countries? We have, I'm listing some problems or some challenges that we have already before the pandemic. So we have a patient with advanced stage with delayed diagnosis, and we have limited care facilities, unequal distribution of the resources, and universal coverage of insurance, and also socio-demographic factor in which our population usually have a lack of awareness for cancer. So this patient, I don't want to scare you with this figure, usually came to us with very late. This is patient with breast cancer, very huge alarm, and also patient with skin cancer, thyroid cancer, and this patient, if we don't give them or treat them immediately, I think they will impact really to their survival or to the outcome. So, during this pandemic, this problem will get severely more severe. So this is a high burden of cancer. I took this photo yesterday. Even during the pandemic, the patients, the cancer patients still need to be treated. There are many patients and the family member, they are needed to be treated, because once cancer patient have been diagnosed, they should not stop the treatment. Because if they stop the treatment, they will have an impact to their life expectancy, and also some complication that may arise if they stop the treatment immediately. So because of this pandemic, we cannot treat all patients like in normal life, because human resources and also equipment and medicine are very limited, because some of them will be allocated to treat a patient with coronavirus infection. So what we have, or we are doing, is to do prioritization and triage for cancer surgery. So we select patient according to the stage of diagnosis and also the aggressiveness or the type of cancer, and do the risk stratification. So we can rate or stratify the need for cancer surgery into urgent. It means that we have to do it quickly, or right now. Less urgent, we can wait, or we can postpone until 30 days or 1 month, or least urgent, we can postpone until 3 months. So with this, we can really select a patient, so or also preserve the hospital resources that is already limited, so we can treat the patient better. This aim for this prioritization and triage is to maximize the health benefit for all patients, but also we can preserve the hospital resources and also protect the patient and health worker from coronavirus transmission. Because if we allow all patients come to, or cancer patients come to the hospital, they also will have a elevated increase to be infected by the virus, because ignoring the social distance. So in this pandemic crisis, as a cancer surgeon, we need also to put attention for the ethical issue, because we do trials and also prioritization for cancer surgery. It means we have to select patient who will get the treatment immediately or who get the delay or postpone. So this will also we have to consider, because each patient they have the dignity or the merit to get the best treatment, but the results is very limited. So this is some consideration that we need to do, and this trace and prioritization and have to be scientifically based. So our aim is to maximize healthcare, and our consideration is the survival of patient have to long-term survival, and also to preserve the quality of life of the patient. So we have to consider that patient need to survive, but also we have to consider the quality of life should be good, because then the patient can be survive and come back to the family and come back to work without any limitation. So we need also have to communicate with the patient and family about our decision, because it will improve the adherence for the patient and family to come back if their surgery is postponed. So we need to make sure that they will come back according to the schedule. Otherwise, we will lose the follow-up, then the patient will not get treated at all. So it will impact to their survival. And all the decisions that we have should be written directly to in the patient chart, a medical record, and also our decisions should be based on the science that we have, and we should eliminate discrimination and nepotism to do this. So I think I got discussed all the points. So this is the summary. Because of the pandemic, and then it will impact all the health system, including in cancer surgery or cancer treatment. And from my opinion and point of view, low and middle countries will be affected more, because we have already limited resources and there is a pandemic, so we need to allocate other resources for coronavirus. And then we need to communicate effectively with other colleagues and also with the patient and the family about our decision. And this is the time for us to act proportionally, because we need to maintain our service, but also to protect patients from the virus transmission, and also to conserve the valuable but limited resources of the hospital. Thank you very much.
Experienced practitioners, we really appreciate and also share the concern, I think, of the complexity in health system in Indonesia, especially for the treatment of the patients who has cancer. That is also why, amid the huge gravity of COVID-19 and amid the government protocol in eliminating the spread of this pandemic, you argue that, or you say that specific considerations should still be undertaken as counterbalance between, on the one side, preventing the spread of COVID-19 or COVID-19 transmission, and on the other side, also preserving patients' long-term life expectancy. Thank you. Maybe sounds overwhelming, but we should accept it, that this COVID-19 dramatically changed our worlds like almost overnight. And there are many more very important and critical analysis and details from both speakers. Now I think I will move to the question and answer sessions. There are many questions in the chatting room already. Maybe I will ask Miss Ninda first, and then Prof. Deng probably, who will ask to Prof. Chandra. The time is yours, Ninda, and then Prof. Deng.
Okay, thank you so much. Thank you very much, PSSAT and Baita, and Prof. Chandra and Mas Lukman. My name is Aninda. I'm from ICC Vissia Institute, Singapore. As I've written in the chat box there, I have two questions to Prof. Chandra. First of all, thank you so much for the eye-opening presentation. It was, for us political scientists, we sometimes forget about the other element of social science, the another historical and also phenomenon that happened in the past, and because we were not aware of it. But I have a question about the 1918 epidemic or pandemic in Java. I'm wondering if there are any certain demographical trends that can be gleaned from infection and fatality rates during the pandemic at that time. This is including the age of groups, for instance, and whether this holds any lessons to dealing with the current situation of COVID-19 in a targeted manner. And the other question is related to the social phenomenon at that time in 1918. Was there any social phenomenon or social response that trigger the spread from as you mentioned before, from Jogja to Magelang to other part of Java, especially Central Java, in your presentation? Was there any social phenomenon? As we know today, we have this Mudik or homecoming session that might be a concern for Indonesian government and also for Indonesian citizens, because it might be causing another wave of the spike in the diagram. So yeah, that was my question. Thank you so much.
Thank you, Ninda. These are really fantastic questions, so I appreciate your asking them. Let me start with your first one about demographics. One of the very interesting things about the 1918 influenza is it was very unusual in the ages of the victims. So a disproportionate number of, normally when you have influenza with other strains of the virus, the people who are the worst affected are infants, so people in the first year of their life, or very elderly people, okay? And of course, people who are immunocompromised. But the 1918 pandemic was very different. It actually took a disproportionate number of its victims from the ages of 20 to 40. These were people in the prime of their lives, right? And there is a story about this. One of the hypotheses is that the infection, why did it kill people who were relatively young and healthy? It triggered an immune response that was so strong that people's lungs became inflamed and filled up with fluid, and so they kind of drowned in their own sort of lung fluids. Now, this is very similar to something that we are seeing today with some of the patients. This ARDS, the respiratory distress syndrome, that a lot of patients are dying from, is considered to be a strong immune response that stops the breathing. So that's a very interesting parallel you raised. But let me come back to age categories. So the interesting thing is for Indonesia, also for Java, I can't say for all of Java, but for the small area of Java for which I have the data, we see exactly the same pattern. People ages 20 to 40 are disproportionately affected by the 1918. Okay? Now, we can make an interesting comparison with what is happening today. Today, what you're seeing is the victims are predominantly elderly people. Of course, you have the usual, I mean, people who have immune problems and other kind of pre-existing conditions tend to be more vulnerable. But it is impacting the elderly mostly, at least in terms of mortality. So it is a very different kind of pandemic. About the social phenomenon of spread, I think that everybody is right to be concerned. At the end of the day, the way these epidemiologic models work is, I couldn't show you all the equations and everything, but the rate of infection depends on the rate of interaction between infected and susceptible people. And the more mobile your population is, the more they are interacting with each other. So the opportunities for infection are increased, and the likelihood that infections will go up is increased as a result. I do want to mention one other very interesting social phenomenon, though. You remember when I showed you the spread of the pandemic into Magelang, it came from Jogja, right? But one of the very interesting stories I read is when the pandemic happened, it disrupted the food production systems and some of the pasars. So you had a lot of hungry people who couldn't find food in areas like Sleman and so on. And so they went up the road to southern Magalang, to places like Muntilan, to the Pasars. Why? And that's what caused the pandemic to spread up into Magalang. It is a specific social phenomenon. I don't think we're seeing the same thing today, but it is specific to 19. Thank you. Two very good questions.
Thank you very much, Prof. Siddharth. Maybe we'll go to Prof. Deng. Please, the time is yours, Prof. Deng. We still cannot hear you, Mbak Santi.
Can you hear me?
Yes.
Yes.
We have learned a lot from your analysis in the 1918 pandemic in STEM and in other part of the world. I have a very short questions. Right now we see the coronavirus has a very strong impact on the world too. And we see the first wave in China and then in European countries. And then right now in the US and in Russia, still very strong impact by the coronavirus. And according to your analysis, you see a few months or several months later, there will come the other wave of the coronavirus. The cases will increase again, like your analysis in 1980s. There's not only a curve, but several curves. So if yes, what kind of regions, areas you think is most possible that will increase the cases there?
Thank you, Professor Deng. That's a really great question. So what the model suggests is if you impose your lockdown very early, you are maintaining a pool of susceptible people, right? So when you lift the lockdown, those people are vulnerable to getting infected. So my first response to your question is, unfortunately, yes, I expect that we will see future waves of this pandemic. And the reason is we still have a lot of susceptible people and we don't have a vaccine. We don't have a way to prevent the disease. Now, if we develop a vaccine tomorrow, then I will change my answer, right? Because then you just vaccinate everybody and you probably won't have waves. But as things stand today, I fully expect that there will be future waves. Now, where will they occur? I think they will occur, first of all, in places where we still have large populations of susceptible people, right? But second, also in populations where the governments and other health agencies do not have the ability to do good surveillance. See, if we do a lot of testing and we can rapidly detect infected people and we can do contact tracing, we can call up everybody that they were in contact with and say, you were in contact with an infected person. Then we can stamp out. We can very quickly stamp out. If we see a few cases, we can keep it under control. So if we have good surveillance, good testing, and good contact tracing, those places, even though they have susceptible people, I think we will be able to manage the pandemic without seeing too many increases. But if we have susceptible people and we do not have good testing, universal, you have to test a lot of people to get an idea about what's going on. Good widespread testing is not available, a lot of susceptible people. And then the climatic conditions. I think we have not proven it yet, but I think that weather has something to do with this coronavirus. I think if you put these three together, conditions where the climatic conditions are favorable for the virus, where there is not good and not universal testing, and there are a lot of susceptible people, those are the places where we're going to have waves in the future.
Thank you.
Thank you. Great question.
Thank you very much. Next one, there is a question for Professor Darth from Pak Khalil Rota. Please, Pak Khalil Rota, the time is yours. Are you still with us?
Yeah,
Yes.
but I have asked my question to Prof. Siddharth earlier, and he has answered by pointing to a paper written by a different professor. So I don't have any follow-up questions. You can go on to the next person. Thank you.
All right. Thank you, Prof. Khalil. Maybe we can move then now to questions for Mas Lukman, for Dr. Lukman. We will go to Mr. BN. The initial here is BN.
Okay.
Yes, please.
Yeah. Thank you very much. Can you hear me?
Yes, very clearly.
Okay. Thank you very much for the presentation. It is very good. Actually, I work in Hannover Medical School, Germany, because I work in rehabilitation field. I just wondering because cancer and cannot be splitted from rehabilitation. It is somehow also supporting each other. Because when I saw the presentation from Dr. Lukman, he mentioned that prioritization for the patient to do surgery is very good. However, I have some question regarding how about for during waiting period, what is your suggestion to the patient to avoid any further complication? For example, their functional and mental complaint during waiting time, and also to avoid long-term effect or consequences because of delay surgery.
Okay. Thank you very much for the question. Yes, because of this prioritization and some patients need to the cancer treatment to be delayed or need to be postponed. We have some criteria for that. For example, patients that have uh, subclinical sign of cancer. For example, if we are going to do like for example, most of thyroid cancer, the well differentiated thyroid cancer, they are they are cancer, but indolent. It means it will grow relatively slower. So we can, if we have already diagnosed the patient with thyroid cancer differentiated, and we can postpone the cancer surgery if the diameter is less than 4 centimeter up to 1 month. So yeah, to avoid the physical and mental complaints during the waiting time, because if we educate patients with cancer, they usually have a response that they are afraid if the cancer get bigger and spread to other part of the bodies. So this is the importance of how to communicate our decision with the patient and the family. We need to explain in according to their knowledge and also their background. So we make sure that they are really understand what the disease they have and what the prognosis of the disease and what the consequences if the surgery is or will be delayed or will be postponed until 1 month. So it will have a negative impact to the patient or not. We have to explain to them. So basically, if we do postpone or if we do delay of cancer surgery, we already consider that the disease will be unlikely to have impact to the patient long-term survival and also quality of life. This is really important for us to communicate with the patient and family. So to reduce the both physical and mental complaint. And also we need to communicate with the patient also about the risk of surgery during the COVID-19 pandemic, the risk of viral transmission in hospital and also from the community. But and also the benefit if we postpone or the not only if we make the surgery happen right now, for example, the risk and also the benefit. So it's a matter about the communication to the patient, and also we open the communication. If we can do distance or virtual communication or consultation. Uh, Although not all patients can do it because our patient, many of them, they don't have the media to do the online consultation.
Thank you very much. One more question, please. If you
Sure.
suggest, for
Go
example,
ahead.
to the patient to have additional treatment during waiting period, will the insurance cover this specific treatment?
Yes, yes, yes. The delay of cancer surgery, usually we also communicate with other field for cancer treatment. For example, from the radiotherapy and also the other part like the nuclear medicine. So, for example, patient with squamous cell carcinoma in the head and neck, because surgery and also radiotherapy is as effective as surgery. So we can communicate to the patient with radiotherapy. So first we do radiotherapy, and then after they finish, then we do surgery, or we do first chemotherapy, and then after that surgery. Because in chemotherapy and radiotherapy, usually they give the treatment in outpatient clinic. So we need less PPA or protective personal protective equipment rather than if we do surgery in surgery room, because the patient came, get treatment, and then patient can go home. So they don't stay in a hospital, and they don't need to be in a procedure of anesthesia. So we know that when a patient needs anesthesia, it means we have to expose the respiratory system of the patient, and get the aerosol during the procedure, so it can increase the transmission of the virus. So if it's possible, we do first other treatment, then after that surgery, if this procedure is as effective as we do surgery first. So we also have to communicate with other colleagues in other field to optimize the cancer treatment.
Thank you very much.
Thank you very much, Dr. Lukman. Maybe we can continue to related questions. It is entangled with the previous questions. Prof. Muksin from Aceh, maybe? The time is yours. Are you still with us, Prof. Muksin from Aceh?
Yes. Hear me?
Not so clearly.
Hello?
Yes. Please go ahead, Pak Muksin.
Thank you very much, Dr. Ita. I would like to ask my Dr. Lukman. Dr. Lukman, can you tell us the complexity of the health system in Indonesia? And is there any relation between the health system in Indonesia and the spread of COVID-19? Another question is, I think is already answered, is about how do you manage social distancing while treating the patient? I think that is my question. Thank you.
From my personal opinion, the health system in Indonesia, it's sometimes it's not really coordinated. So each region or each hospital, they have the policy to manage the patient with COVID-19, and also to manage other or maintain other service for example, for essential medicine, or including emergency in surgery or emergency in obstetric and gynecology, for example. So, but I think there is one paper from Indonesia also. They tell about how the government, the community, and also the health system respond to COVID-19 in pandemic in Indonesia. And there are some also regulation that already released by the Ministry of Health about how to regulate the COVID-19. But the lack of the response from the government and also from the authority is the coordination. So really in the bottom up for the doctor, we need to interpret the regulation and also how to implement in our clinical setting or in our own hospital. So I think it will be variation in one hospital and the other hospital and how to manage it. So I'm not sure if this will implement to all the hospital in Indonesia in the same way. So that's the limitation in Indonesia, I think. So and also for example, the how they maintain the availability of the PPE for health workers, and also how they protect the patient from virus transmission, because the availability of the PPE is also very important if the hospital want to maintain the service during the pandemic. Thank you.
Yeah, and the relation with the spread of COVID-19.
Repeat again. Hello.
Yeah, you explained the complexity of the health system in Indonesia, but what is the relation with
For the
this?
patient with COVID-19 infection or COVID-19 disease, the complexity, because first we don't do like the screening like there in other countries. So the complexity is that when the patient came with the symptoms and also with the history of contact with other with the patient or with the suspected, then the doctor need to explore from the beginning, do the test screening and also the treatment if needed. So the complexity is that first is the screening itself. It's not, I think, available in every center. And the second is the diagnostic test, especially for swab and the PCR. It's not come faster. We need to wait for a long time for the result to come. And then the calculation for patient with positive based on the swab. And the complexity also happen when the patient from our experience in our hospital, that the patient is not positive with COVID-19, but they have the symptom and the rapid test is still negative, but the PCR is not yet come up. So the patient has already been treated because they have severe acute respiratory distress. And many of them, they suffer from this disease and come with mortality. So the complexity is that how the health worker and also the nurse and also ask how to treat this patient, because we need to treat this patient as a COVID-19, but this is not really positive. So also at the allocation for that, because they move already some resources to become intensive care and to differentiate between patient with positive, suspected, and negative. So this really take so much human resources for that, and also for the facilities that the hospital need to provide. And then of that, I don't know the real help from the government, because they also there is separation from the building itself and the facilities, which one need to be code as a green, red, and yellow, and then to separate the patient and also the family member who visit the hospital from the, and to limit the virus transmission in the hospital.
Thank you very much, Dr. Lukman. There is another question from Miss Santi. She put it in Indonesian, but more or less it's like, considering the fact that there is a decline for patients, patients referring to cancer, does it also influence the awareness of the patient about the cancer itself? That is the first one. And then the second one, maybe about the priority, whether to eliminate the spread of the transmission of COVID-19 and also the cancer patients itself. Dr. Lukman. You can also see from the chatting room if it is not so clear yet.
Hello, I could not hear clearly.
Mbak Santi? Can you hear me now, Dr. Lukman?
Yes, yes.
Right, there is a question from Ms. Santi. She says that considering the fact that there is a decline for the patients to refer to the health facility, does it also influence the awareness from the patients itself about the disease, about the cancer?
Yeah,
That is the first one.
from this, okay, yeah. Thank you very much for the questions, because this also we consider that some cancer patients that need to get treatment, they are afraid to come to the hospital because they are afraid to be contracted or to be get infected within the hospital. We consider this, and but we don't have any a real solution for this, because if we there are some regulation from the insurance, the BPJS insurance, that the patient, for example, if patient now is need to be treated in a cancer center because they need a regular medicine, for example, for hormonal therapy or for chemotherapy. The regulation from the insurance is they need to come to the hospital so we can get the write the medicine for them. But for solution in the online consultation and the prescription of the medicine and the coverage with insurance, we don't have any solution that. For that, because we need to that the patient can come. But the only solution is that if the patient needs regular treatment, we usually they need to come once a month, but because of this COVID-19, they can get the medicine for 2 or 3 months, so they can come every 2 months until the pandemic is over.
Hopefully it will over soon. Dr. Lukman, thank you very much. All right, we still have a couple of minutes. Maybe the last question for Professor Siddharth, Elo from Italy. Please, your question. The time is yours.
Okay, can you hear me? Yeah.
Yes.
Hello. Thank you, Professor Chandra. My question is just about the economy in Indonesia after the end of the pandemic. I would like to ask your opinion about how the growth of Indonesian economy still have after the end of the pandemic, or there are like huge consequences, like increase of the poverty and the increase of employees in the inequality. And what is your opinion about that? Thank you.
Thank you. That's a great question. So I am an economist by training. I don't know if I mentioned that in the introduction. My sense is that, again, I try to take whatever hints I can from what happened in 1918. In 1918, it took about a year and a half or two for most economies to fully recover from the pandemic. So I think there is good news. I think that we will come out of this, but it will take a year and a half, probably even 2 years, to see a complete recovery. Now, the speed of that recovery is going to depend on how confident people are that they will not get infected if they start to go about doing their business freely. So that's the most important thing, is the confidence of people to go out and buy and engage in the usual transactions, economic transactions that they engage in normal times. And that will obviously depend on the number and spacing of future waves of infection that we see. I'm almost certain that there will be future waves. We just don't know how many there will be and how long into the future these waves will keep occurring. That will affect our behavior. But I think a year and a half to 2 years is a safe estimate of the timing. Now, in the meantime, what's going to happen is people who depend on interaction with other people for economic activity. For example, service industries. If you go to a restaurant or you go to have your haircut or whatever it is, I think those industries are going to be affected until mobility returns to normal. And the role of not just governments, but I think civil society more generally. In the U.S. economy, the government announced, multiple trillion-dollar package of unemployment benefits, other types of benefits to companies like airline companies that are losing business, to keep them going in the short run. Countries like Indonesia perhaps have more resource constraints, and I think it's going to be much more important for non-government actors also to be involved. I've seen that in my country of origin in India. A lot of people in civil society are very conscious of the situation around them. People who are in a position to be generous are being generous. A lot of donations coming into neglected areas of the country, economically neglected areas, to help feed people. So I think it's more than the government. I think it's a whole of society effort to make sure that the basics are taken care of for the most vulnerable people. And then I think things will pass. Hopefully in a year, hopefully less, but probably in a year and a half or two.
Thank you for the question. I will like just another question, like more micro. For example, city like Yogyakarta or Bali, they live for tourists. I mean, all the money is for tourists. And these 2 years stop tourists, there are a consequence. How this will change Yogyakarta or Bali itself or not? How can say grow after 2 years? It's no tourist.
That's a good question. Maybe we should ask our friends in Yogyakarta. They may have a better idea. It's very difficult to tell. There are many economies in the United States and in the Caribbean, close by the Caribbean Sea, which are very dependent on tourism as well. I think those economies are going to turn inward temporarily for the next year and a half or two. They're going to move a little bit more in the direction of subsistence, not completely, but more in the direction of subsistence for a year and a half or two. And then they'll come back. What kinds of activities some of these newly employed or underemployed people will engage in, it's very difficult to tell. I think it will depend on the local circumstances and what local economic opportunities are available in the interim period. In some areas, it may be agriculture, people who maybe worked in hotels or, maybe selling food on the street. They may end up returning to their home villages, helping their families with agriculture. Others may find alternative employment. Certain other sectors of the economy may end up growing as a result. You can see that right now we're on WebEx. We know that in the tech sector, this may not apply to Jogja specifically, but there are aspects of the technology sector that are booming. Online shopping, for example, is booming. That may not be a reality for a lot of people especially in rural areas of Indonesia. But I think we need to start thinking about what are the alternative sectors into which people will go. And there surely are some. Whether there will be enough to absorb everybody, I think it's difficult to say. I think not. I think there will be a spike in poverty. There will be a spike potentially in hunger if that poverty is not taken care of. I think that's really what we need to pay attention to.
Thank you very much, Prof. Siddharth. I'm afraid that we are approaching 9 p.m. now, and we will give the chance for each speaker for a closing statement. Maybe we can start with Prof. Siddharth first, and then later Dr. Lukman.
Thank you, Bu Ita. So just in closing, I just have one message. And the message is, remember your pandemics. There's a saying, people who forget history are doomed to repeat its mistakes. I think this is a classic example of that. If we had been more aware of what happened in 1918, if we had consciously integrated the lessons of the 1918 pandemic into our health infrastructure, I think we would have bought at least 1 or 2 months worth of time. We would have been in a much better position today to manage the pandemic than we are right now. Right now, we are learning as we go. We didn't need to. Thank you.
Thank you, Prof. Siddharth. Dr. Lukman, please. Dr. Lukman, can you hear me? You can put forward your closing statements. Are you still with us, Dr. Lukman? Mbak Santi, maybe there is technical problem. While waiting for Dr. Lukman for his closing statement, we do agree that the magnitude of this COVID-19 is really huge, and we are so overwhelmed. It hijacked every dimensions of human life, and everyone, I think, is nervous, and no country is ready for dealing and coping with this COVID-19, with the spread of this transnational virus. And I think we should really agree with Professor Siddharth that we really have to learn from our past pandemic. Right. Dr. Lukman is there?
Yeah.
Yes, please. A closing statement.
Okay. I think for me, everyone can contribute to this fighting against pandemic. Doctors, social scientists, epidemiologists, everyone can contribute. So let's contribute actively to the community, to the government, to ease and win against this pandemic.
Right. Thank you so very much, Dr. Lukman, and also Prof. Siddharth. I will not conclude anything, but one thing for sure is that we should hand in hand fighting against coronavirus. And thank you very much for your active involvement. And from Aceh, from the US, we thank also from AIFIS, from Italy, from Germany, from Surabaya. Thank you very much. Maybe you want to say something, Bu Hermin?
Oh, I think, yeah, that's a very nice presentation. We learned a lot from both presenters. And thank you all that joined us this evening. We really aware that this is a very critical time in Indonesia, but still so many participants can join us. Thank you. And yeah, we meet again in the next discussion. Thank you very much.
Thank you very much. See you offline.
Thank you, Bu Hermin. Thank you, Bu Ita. Yes, I look forward to seeing you.
Thank you.
Great. Okay.
Bye-bye.
Bye.
Thank you.
Bye now.
Good night.
Bye,
Good
thank
night.
you.
Thank you very much.
Thank you, Pak
Bye.
Lukman.
Yeah. Makasih Pak Abe, makasih Pak Muksin.